care for children with alterations in bowel elimination, gastrointestinal disorders today. So the big thing is your GI, your gastrointestinal system is basically, it's your mouth to your anus, right? It's the whole thing. There are, of course, like you've learned throughout the course of this, there's gonna be physiological differences between kids and adults, right? They're not just little adults. One of the biggest things is when we talk about oral, everybody has very vascular mouths. But why with children is it more of a common site for infection?
With everything in their mouth.
With everything in their mouth, right? This is how infants and small children explore their world. So they're getting exposed to more, they're more likely to have injuries from putting stuff in their mouth, so they get exposed to a lot more. And then why do we think that oral hygiene is a critical assessment? Another thing.
Because like teeth infections get
Yeah.
really bad.
Yeah.
And can lead to serious complications.
Exactly.
People don't
So
realize that.
if they have dental caries and things like that, or poor oral hygiene, that's more bacteria in their mouth, right? So that's another source of infection. So we have to think about that bacteria, but also, like we said, kids put everything in their mouth, right? So it's not even just germs. They're putting dirt, and then they get exposed to other things like parasites and worms and all kinds of gross stuff, right?
They'll scratch their butt and then put it in their mouth. It's crazy.
Yeah, so that's a big source. And then the next on the list is the esophagus. So obviously they have shorter esophagus, right? Everything's smaller, but that, there's a picture on the next slide, but that lower esophageal sphincter, that muscle that blocks off your stomach from your esophagus, that prevents acid and food and stuff from flowing back up. It's immature. That muscle hasn't developed enough tone to really control well. So up until they're about a year old. So that's why a lot of times you have babies that have acid reflux or GERD, or have vomiting, because that muscle's just doesn't have the muscle tone to keep everything down. Okay. So this is where nursing care, proper feeding. If you have a patient, a baby who's prone to vomiting, teaching the parents about proper techniques for feeding the baby, holding the baby. A lot of times they'll say keep them upright for half an hour after they eat to avoid that reflux. Sometimes they may need medication for it to control the stomach acids. And then their stomachs, of course, are smaller, right? A newborn can only hold about 10 to 42 mils. So kids are going to eat more frequently, right? Because they can hold less. So that's the same thing with medications and fluids. We have to think about that and do smaller doses at a time. And that's kind of important too when we talk a little bit about oral rehydration in a little bit. Overall, I'm gonna kind of skip ahead, but overall their entire GI system is not really mature until they're about 2 years old. So when we think about things like their intestines, their pancreas, their entire biliary system, your body makes a lot of enzymes that help with digestion. Because of that immaturity, they don't make a lot of those enzymes. So for example, they have a hard time breaking down carbs and fats. Those pancreatic enzymes, they have a hard time, again, with fats. So this is where it's important to think about formula choices for infants that are formula fed. And that's why kids, they say to introduce foods at different levels, because it's when their body can handle the digestive process. Okay. The other thing with kiddos is they have more body water overall compared to adults. So because they have greater extracellular water, they're more susceptible to dehydration. They're more susceptible to water loss and electrolyte imbalances. So things like vomiting and diarrhea, they'll get dehydrated a lot faster than an adult will. Things like high fevers can contribute to them getting dehydrated faster. They also have a higher resting metabolic rate than adults do. So that's burning energy, right? So that can increase water loss even in a well child. So overall, we have to think about the differences that they have other than just the size itself. questions on that so far? Okay. So, physical assessment, it's gonna be pretty much the same as your adults though, right? When we are, of course, you're gonna start with the least invasive to the most invasive your inspection. When you're looking at the abdomen and chest, you're kind of looking at everything all together because it's a small area. So you're not just looking at symmetry and size. Is there any kind of distension? Is there any kind of discoloration? Is there any kind of injury? Any kind of masses or anything? And then we go to listening. Are they hyperactive? Are they hypoactive? Are there no vowel sounds? That can kind of be an indication of an obstruction, right? Or if you have abnormal sounds like obstruction, sometimes you'll hear like almost like a little tinkling sound, a metallic sound. That's a sign that something's not right. So it's hopefully you just have your natural active vowel sounds throughout. Percussion, and I think we've talked about this, you guys probably have before, we don't really do a lot of percussion. Things like we just don't really do that. Palpation, with newborns, sometimes you can feel the lower edge of the liver just because it's so large compared to their size. Usually that's about it. You can't palpate the kidneys. If you can, that might be an indication of some hydronephrosis. One thing we do palpate for though is right lower quadrant pain. That's usually a telltale sign of an appendicitis, right? That and that flank pain. Like I said, but also important if your inspection, you're really looking at color. Are they having any kind of pallor? Are they having any kind of discoloration in their skin, like a jaundice, or any kind of injuries? Excuse me. So, of course, when we're talking about GI, we're going to talk about different, some of the different diagnostics that we do. So, one of the big ones we do, and it's not on here, is a KUB, kidneys, ureters, bladder. That's just your basic abdominal, your abdominal X-ray, right? So, what kinds of things were we looking at? What would make us want to do a KUB or an abdominal X-ray on a kiddo?
Recurrent kidney infections.
Not pooping, not peeing. What else?
Recurrent urinary tract infections.
What would we be looking for?
To see any malformations in the urinary tract. See if maybe the kidneys are a little bit lower than the bladder. Make sure that the ureters are traveling down instead of going up.
Good. What else? Any kind of complaints of abdominal pain, constipation is one because we can see the stool burden in there. If you have like abnormal liver enzymes or abnormal liver labs, we can look at that and see. Or masses or foreign objects. If you suspect that they've swallowed something, an X-ray is a really good way to see that. Another one would be an abdominal ultrasound. And same thing, if you're having any kind of abnormal pain, or we really want to get a good look at those organs and see structurally, are those organs okay? Is there any kind of a mass? Is there any kind of swelling? Anything going on there? Excuse me. And then a barium swallow. Do you guys know what would that show?
Difficult on swallowing.
Mm-hmm. Yeah, it'll be that white, it'll show. So that's gonna show exactly. So you're gonna, whatever you're looking at, you might follow it all the way through. We're looking at any kind of difficulty swallowing, any kind of like regurgitation. It'll also show, as it goes through the intestines, it'll show that peristalsis. So we can see if there's any kind of motility issues. And that you can follow all the way through, which is kind of nice. It can be good for showing if there's like a malrotation in the intestines, which maybe would be hard to see on like regular radiograph. when you're watching that barium go through, you can kind of see where it gets really skinny or it kind of looks funny. And then, what kind of blood work do you guys think about when you think about GI stuff? CBC, what's that gonna show us?
Blood loss.
Okay. Blood loss, anemia, infection, right? Your white count, what else? Urine creatinine. We're gonna look at kidney function. Is there something going on in the kidneys? Your livers. I'm sorry? Oh, we can measure some of those enzymes to see if they have some kind of deficiency there going on. And then also, I skipped the small bowel, so that's just a series of x-rays, but that's really good for looking at things like if they have like irritable bowel, you can maybe try and identify areas of inflammation, see what's going on, or for diagnosing intussusception, which we'll talk about. And then another big one is the occult stool. So sometimes you might have trace blood in the stool that you can't grossly see, so that can be really helpful in identifying some of those other diseases, like if they have like Crohn's or something, or if they're having like malabsorption issues. Is there some kind of bleeding somewhere in the GI tract?
Is that the same as like the fit test, or
Is the what?
the fit test, or is that specific to colon cancer?
No, the occult stool is just, it's like a little card and you put like a little drop of stool on it and just test for blood in the stool is basically what it is. It's strictly for blood. Okay, so of course we have to get creative. If you have a kid that you have a suspect has some kind of a parasite or a GI bug or something, or you need more diagnostic stuff, gotta collect stool, right? So diapered kiddos, if it's nice and formed, it can be really easy to just scoop it out. If it's not, if you're having a child who has severe diarrhea, that's a little bit harder because the diaper's just gonna absorb it, right? So some of the things you can do, I don't know about that plastic wrap. I think that's just gonna make a giant mess.
Yeah.
But what you can do, swim diaper, those can get messy too though. But what you can do is take the urine collection bags. Have you guys seen the pediatric urine collection bags?
Yeah.
They're little. You can just move that back more and hopefully you can catch enough stool in there to be able to send off. Older kids, obviously bedridden kids, you can get them to go in a hat or in a bedpan. You just need to be really careful, and it's a little bit more challenging with children because they don't always understand what you're wanting them to do. You really want to try not to mix it with any urine if at all possible. Like most things with kids, we do our best, right? Excuse me. So when we're talking about acute gastrointestinal disorders in children, basically the ultimate end goal is we're worried about what? I'm sorry? Dehydration. Whatever is causing, we are worried about bleeding, that's serious, but we are worried about ultimately with all across the board, when you have a kid who has a GI disorder, we're worried about dehydration. Remember, they have that excess, they have greater extracellular water, and they dehydrate very fast. The other thing is, what's the first thing kids do when they don't feel good? They vomit, they stop eating. When they don't feel good for any reason, they don't eat and drink. So if you have a kid who's not eating and drinking, you have a kid who's vomiting or who's having excessive diarrhea, it's very, very easy for them to hydrate quickly, to get those electrolytes out of balance quickly. So when we're looking at, this is signs of like a mild dehydration. So for infants, we're gonna look at those fontanelles, make sure they're not still sunken in, look at their skin turgor, look at their color, look at their mucous membranes. They're probably gonna have decreased urine output, be tachycardic, and they may be lethargic, just because they're not feeling well. Those electrolytes are off. The most common causes of diarrhea in small children are going to be things like a gastroenteritis, things, oh, sorry, wrong way. I'm gonna hit it on accident. Ha, sorry. Are gonna be things like gastroenteritis, anything that's gonna cause that GI upset, like bacteria, like E. coli, parasites are really big because again, they're putting everything in their mouth, right? Viruses, things like medications can obviously cause it. Most kids, any antibiotic you give them is gonna give them diarrhea. Food intolerances, but then we also think about more chronic cases like celiac and Crohn's, that type of stuff. So any of those diarrheas are gonna cause it. Vomiting, of course, decreased oral intake because they don't feel good, they're not taking it in. High fevers can contribute to water loss and dehydration. And then while they're not GI, DKA, of course, because they're breathing off all those ketones, right? So they're losing water that way. And then extensive burns, just because they don't have that skin, that protective covering to keep everything in. So how do we fix dehydration in any instance, no matter what's causing it? IV fluids, oral fluids, fluids. So any of these, of course, your chronic issues are gonna take different paths, but any chronic cause of vomiting or diarrhea is gonna be supportive care usually, right? So the first thing we talk about is fluids. We need to get them hydrated. What's the best thing to hydrate them with?
Like D5.
Oh, well, we're talking oral first.
Oh.
Sorry, I should have specified that. So the first thing we're gonna do is if they are mild dehydration, they're showing those mild symptoms, we're gonna try to do an oral hydration, okay? We're gonna use a Pedialyte, something like that. You are going to offer it very, very slowly, okay? So just like a little syringe full at a time, see how they do. We're not gonna give them a bottle of it, we're not gonna give them a sippy cup of it, because if they decide they're well enough, they might not even drink it if they're not feeling well. So that's another reason why the syringe is helpful. But if they're feeling thirsty or they're feeling well enough to try and drink, they're probably gonna drink it down really fast, and then what are they gonna do? They're gonna throw it right back up. So we use an oral syringe, we go very slow. So we are going to keep very close signs of what their intake is. Of course, we're monitoring their output the entire time, and we're gonna hopefully see if they keep it in or if they continue to have worsening signs of dehydration, where at that point we would go to the IV fluids. So when we talk about oral hydration, I think I usually say, like when a kid is sick, I say give them whatever they want, right? Whatever they'll take in. But when we're talking about actual rehydration, we need to be very careful. So things like, the reason we say Pedialyte is because it has not only the fluid, but it's got all the electrolytes in it. If you do things like tap water that doesn't have any kind of electrolytes in it, right? And especially infants, we don't give them straight water. So that can lead to hyponatremia, and create worsening electrolyte imbalances. And then what can that cause? When your sodium's off? Neuro seizures. So we need to be really careful with that. We definitely don't want to do milk because that can exacerbate diarrhea and vomiting, right? And it's not going to help at all with their electrolytes. Fruit juice, same thing, that can contribute to diarrhea. Doesn't have the electrolytes we need. Soups and broths, it's not gonna have that good balance. And sport drinks, they usually have too high sugar, which kind of falls in with with the juices. So it's not gonna have as good of a balance. So we're gonna start with that. If they either won't drink it, aren't tolerating it, have worsening symptoms, or are not able to swallow for whatever reason, we're gonna go to IV hydration. So then we're looking at more of a moderate to severe. Those fontanelles are really visibly sunken in. They won't be urinating. They'll cry but not have tears. That's a sign of severe dehydration in babies. Their mucous membranes will be dry. Their cap refill will be over two. They'll definitely be lethargic, and they'll have cooler extremities because they don't have that good perfusion. So this is where we really need to get it into them. So we will do either normal saline, or most commonly it'll be lactated ringers. Okay. And it'll be 10 to 20 mils per kilo. And you wanna get that in quickly. So usually like 10 to 20 minutes. If need be, oftentimes you'll have an order to repeat your bolus one time. You wanna assess them very closely. What are you assessing for after each bolus? Sorry?
Like their lungs.
Their lungs. Why is that important?
Get them comfortable.
Yeah, we wanna be careful we're not overloading them, right? So you're going to, after each one, you're gonna, of course, reassess for signs of hydration, right? Everything that you've already looked at. Do they have any urine output? Do they have tears? What does their mucous membrane look like? Does it look any better? What's their skin turgor look like? Has their cap refill improved? All of those things, but also keep a close eye on those lungs. And that's why you won't do more than 2. It'll depend on what you have for doctor's orders. A lot of times you'll do that rehydration and then just go to like a maintenance fluid. So of course, we're gonna continue to monitor their vital signs, like we said. Hopefully you'll see a decrease in heart rate, lung sounds, work of breathing. And then our urine output, we're gonna go for a goal of 1 to 2 mils per kilo per hour. You're probably not gonna get that right away. It's gonna take them a little bit of time to balance out. Sometimes it can take them, if the kid is severely hydrated, it can take a couple boluses and a whole shift before you'll start seeing some output. You might wanna consider a catheter if they're critically ill. We don't usually, but what's one thing you can check to see if they're producing urine, if they haven't peed yet?
Bladders.
Bladder scan them, see where they're at. Okay, that's not real invasive, and you can kind of see what's going on. Okay, do you guys remember this from clinicals? We think we did it like day 1 with the maintenance fluid. So remember, this is for just maintenance, not for the rehydration. If you have a kid that weighs 10 kilos, or up to 10 kilos, the first 10, it's 100 mils per kilo per day, right? Then you divide that. And then if they're up to 20 kilos, you add an extra 50 mils per kilo. And then above 20, you add 20. You guys remember calculating it? I think that was like day 1, wasn't it?
Yeah.
Yeah. Okay. And then you would just divide it by 24 hours, and that's how you come up with your hourly rate. Questions on that? Excuse me. So then we talk about, that's more about like acute, like disturbances, like bugs and stuff. But also you have things like obstructions that can cause diarrhea in kids and vomiting kids, right? So some of the big ones are intussusception. Do you guys remember what that is? What is that? Not twisted, it's that, but Bailey's got it. It's got that telescoping where it folds in on itself. So if this is your intestines and it goes, boop. So it is extremely, I can't speak from experience, it is extremely, extremely painful. They'll have severe crampy colicky pain. So you'll see them like pulling their legs up, you'll see screaming. It's sudden onset. And if you look at an ultrasound or a x-ray, it'll kind of look like a sausage shaped. It'll look kind of funny. And the telltale sign, hallmark sign of it, is what's called current jelly stool. So their stool will be like blackish red, like jelly. So that's, and of course that's causing blockage, right? Because stool can't pass through. Do you guys know how that gets repaired? There's one thing we try before surgery.
NPO.
I'm sorry?
NPO.
Oh, they're absolutely NPO.
NPO and,
Enema. So it's actually the first thing they do is they do what's an air enema. So they blast air in to try and see if they can push that back open again. Remember things like, again, day one, we had the baby who couldn't get the rotavirus vaccine because she had a history of this. It's most common in infants 3 years up to toddlers and 3 months to 3 years, but it can happen at any age. It can happen to adults even.
My friend had a giant with her baby.
And I'm sure it was extremely painful.
They did it.
They did the surgery. Yeah, and I'm sure it's extremely painful. You guys have a lot of nerves in your GI tract, so I can imagine it's extremely painful. So the other things that we talk about that can cause kind of obstruction, that can cause obstructions are a malrotation and volvus. Do you guys, who can tell me the difference between the two? Do you guys know? So a malrotation can actually be any kind of abnormal rotation in the intestines. If it's got like a kink or it just doesn't kind of turn right. Yeah, it can do kind of, a volvus is where it actually, what she was talking about, where it actually twists. That would be a volvus where it actually twists. So with any of these, you're gonna again see severe abdominal pain, you're gonna see bloody stools, you might see bilious vomit. Any three of these, because they are causing an obstruction in the bowels, are going to be a medical emergency. Because what happens when the bowels are twisted off like that? They lose circulation, so they're gonna start dying. So when you have things like any kind of malrotation or volvulus, that's a surgical emergency, that's an immediate repair. So what they do is something called a LAD, L-A-D-D procedure, where they go in and straighten out the intestines and kind of tack it back to the mesenteric wall the way it should be. They're all bad. They're all, I'm sure, extremely painful. Any of them are going to be diagnosed by ultrasound or that small bowel series. Questions on those? Yeah, obstructions are always an emergency. We don't want to lose intestines.
Do they ever resolve themselves, or do we always?
We always, because it's an emergency, you don't want to sit and wait. Because bowel dies very quickly. And once the bowel starts becoming necrotic, that spreads very quickly as well. So, and you have to think about kids we'll talk about short gut, but any kind of loss of bowel can be serious because they're still growing and developing, right? Infants have like, I don't remember what it was, but they have like a third of the length of small bowel that adults do. So however much we take out, that's less that's gonna grow. So the other thing that we look at, and you don't really think about it as it being part of your GI tract, but remember it starts with your mouth, right? And this affects your eating, is cleft lip and palate. So this is actually the number one most common craniofacial anomaly in children, and there's an incidence of 1 in 700 births worldwide. And it can be varying degrees. It can be either just the lip, it can be the palate, it can be unilateral, it can be bilateral, it can be complete or it can be partial. There's a lot of different options, a lot of different presentations that they can have. Of course, all of them, the number one thing is feeding difficulties, right? So your cleft, and this all develops during gestation. So normally your tissues that form your lips fuse together in 5 to 6 weeks gestation. So for whatever reason that didn't close properly, and then the palate closes between 7 and 9 weeks. So with these kids, usually at 3 to 6 months, if it's just the lip, or they'll go in and do the lip part of it, and then the palate repair between 12 and 18 months.
Actually, because my daughter's at 8 months.
At 8 months, was hers both lip and,
The cleft only.
the lip only,
The
or
cleft.
the palate? And she did okay after that?
Yeah, she needed 3 more surgeries.
Yeah, it usually is a series of surgeries.
Yeah, because she had, so they closed it, and then she had speech therapy, and they noticed that she had nasally,
Okay.
air coming through her nose.
Yep.
So they did what is called like a buccal palate repair, where they take some, tissue from her cheeks, cross it over to close more on it,
Okay.
and then she had to stop eating like only liquids for like a whole month. And then they went back again and then cut the tissue after they knew that it had, stayed there.
Okay, so just to
Because
stabilize
yeah, because
it.
they use their own tissue instead of using any.
Yeah. So you can see how extensive this can be, right? It usually is a series of surgeries. They usually have feeding issues, obviously, because they can't get a good suction, right? So there's special bottles that can help. Often these kiddos, they will have delays in speech. They will have alterations in their development of their teeth. Sometimes they are more susceptible to things like ear infections, sinus infections, because that's kind of all open. So they're gonna have a really extensive care team. They're gonna not just have their surgeons, but they're gonna have speech pathologists. They're going to have their craniofacial. They're gonna have dentists and orthodontists, oral surgeons. Oh, sorry, I skipped one. The other thing, and we don't know why this is, because it's part of fetal development, but children with cleft lip and palate also can sometimes have heart defects, skeletal deformities, ear malformations, or genital urinary, like they'll have kidney or problems with their ureters is commonly together. Okay. Case study time. I'll let you guys read it. You don't have to listen to me.
There's like education, therapy. Oh, bias, I think, especially yeah, 100%. No family pictures,
When he was alive.
I know me too.
Okay, so for this kiddo, what kind of things, do we wanna consider when we're getting their, health history?
Their emotional state
Their emotional state of who?
of the parent and the child.
Yeah,
Because parents sometimes can take two routes, they can either blame themselves or they will blame the child. Like, oh, this is embarrassing.
it's pretty sad, but it's possible, yeah. People, everybody wants to have that perfect baby, right? You don't have a kid, there's something wrong with it. Okay, emotional state, what else do we wanna find out about? Definitely, absolutely. That's gonna play an important role in their care, right? And how we proceed. What else did you guys think of?
Any prior procedures?
Yeah, has he had any kind of repair started? Has he had any kind of speech therapy or anything like that yet? What else?
Basic family history.
Family history?
So you said we should definitely put the need for an interpreter to ensure communication.
Yes. Step
Absolutely.
one's interpreter.
Absolutely.
Thus far.
Any kind of feeding, yeah, any kind of feeding. Any kind of feeding difficulties that he had during infancy, or, you know, as a 3-year-old, how well is he eating? Cause if he's not eating well, then we're worried about him having like malnutrition, failure to thrive, things like that, right? Any kind of respiratory issues, any kind of frequent infections. And then we also wanna know about, gestational history, right? How was mom's pregnancy? Did she have any kind of illness? Did she take any kind of medications? You know, maternal age, smoking, anything abnormal during the pregnancy, right? And then, what would be included in his teaching plan?
Options for treatment, aftercare, what to look out for, nutritional, probably consultation.
Yep. Anything else you guys think of?
Resources.
So some of the things that they have on here are, obviously preoperative teaching, what to expect, for the procedure, nutrition, post-operatively. Is he gonna have any kind of diet restrictions? Like, will he just be on a liquid diet until this is, until it heals, because we wanna make sure it heals properly, right? We don't have more complications. Comfort measures. It says to prevent vigorous crying post-operatively, because that's, I'm sure, extremely painful. And then assess and assist with parent-child bonding if necessary. Like she said, maybe the parents are not coping well with it. And then what resources could the nurse give the parents to help with emotional support?
Therapy, support group.
Support groups, there's a foundation called the Cleft Palate Foundation. There's an organization called Operation Smile, which is a team of doctors and dentists and therapists and like speech therapists and psychosocial therapists who go all over the world to help people. One of our doctors at Thunderbird is on a team, and she's been all over to help these kiddos. It's kind of cool. And then lastly, what would be a major challenge in the nursing care for Galib and his family? You guys have kind of hit on a couple already, but
Their attitude towards the whole situation. It could help us or it could.
yeah,
The language barrier.
language barrier is huge. We need to make sure that they are understanding everything that we're teaching them so that they understand the risks, the precautions, the benefits of doing this procedure, but also what to expect so he has good aftercare, right? So we absolutely need to be worried about that.
Would their access to resources also be a challenge?
Mm-hmm. Yeah, they haven't lived here very long, right? So they're recent immigrants. Are they staying in like a hostel? Do they have permanent housing? What kind of resources do they have as part of their immigrant?
Or do they know
Status.
how to access resources? Cause when I moved here, it took me like a year to know where to go for like insurance, dental and all that stuff, so.
So who's a big person to help them with that? Social work, yeah. Make sure that they have all those things. So definitely his age is a factor because he's 3. You can't really explain to a 3-year-old, hey, you're having surgery. This is what you need to do, right? We need to get on his developmental level. Family's understanding of English, we're gonna have language barrier, understanding the procedure, understanding their resources, knowing their resource, and then cultural, we have to think about. Very nice. And you have to think too, at 3, the parents might be like, well, do we even need to do this? He's 3. So they need to know the long-term repercussions. All right, it's 10:12. Let's take a 10-minute break, okay? And then we'll continue on with our wonderful GU stuff.